Everybody, we move forward to the next lecture number 9, regarding hypoparathyroidism, bone turnover, and osteoporosis. Hypoparathyroidism is, like the name it says, the inability of the system to produce PTH or to sense PTH according to the needs. The principal landmark is hypocalcemia, which can be either to lesional, meaning lifelong, permanent, untreatable causes of hypopara, or functional, self-limited standby of the parathyroid, which under special circumstances will resume the normal function. When we think about permanent, there is some functional, some organic cause, and it's surgery, of course, in secondary hyperparathyroidism when we choose to take 4 out of 4, and of course we have permanent hypopara. By mistake, when we have the excision of all parathyroid active tissues in situation with thyroidectomies along to the parathyroidectomies, which is usually in huge goiters in situation in which the surgeon is unable to identify the parathyroidal tissue due to the volume of the goiter, or secondary ischemic mechanism because of the ligature, especially of the inferior thyroid arteries. Even if we administrate radioactive iodine in case of thyroid cancer, we do not aim parathyroidal tissue, and parathyroidal tissue does not uptake actively the radio-labeled iodine. But if there is a remnant tissue in the thyroidal bed which will uptake large quantities of radiation, that can be sensed by the parathyroids, which also are present in the lesion and can activate the DNA alteration and the apoptotic mechanism of parathyroid involution. This is the cause that in some situations, especially with active remnant tissue, when the patients are treated in the nuclear medicine department, there's an active follow-up also in PTH when we perform thyroid follow-up. Infiltration of the thyroid, sarcoidosis, Wilson disease, hemochromatosis, different type of metastases, autoimmune disease in which we have anti-parathyroid antibodies, especially in the autoimmune syndrome type 1, along with autoimmune thyroid deficiency, adrenal insufficiency, or ovarian premature failure. We can have parathyroid dysgenesia, either isolated, like in DiGeorge syndrome, in which it's parathyroid and thymosagenesia, or we can have some mutations, recessive mechanism, PTH gene mutation, in which we have an alteration of PTH production by the parathyroid glands, or dominant autosomal mechanism, we have mutation of the calcium sensor on the surface of the parathyroid, meaning the parathyroid does not feel correctly calcium level, and the threshold of PTH secretory mechanism is different according to the normal population. And in long-standing untreatable situation in which all of these are excluded, we can say it's an idiopathic without evident cause form of hypopara. So again, either we can have a mutation of the PTH gene in the genetic form of disease, in which we have an alteration of the release when we have command from the calcium sensor, or we can have a mutation of the calcium sensor, meaning it's an impairment of how quick this sensor feels hypocalcemia, and of course the mechanism of PTH secretion and release is altered. Regulation, we know about the sensor of calcium on the surface. We also know we have a receptor of the PTH. PTH is produced by the parathyroid chief cells. It is sensed at the level of kidney, tubular cells, and the level of bone. Any situation in which calcium is high will downgrade the calcium sensor receptors and will induce the active degradation of PTH, preprohormone, in inactive PTH. Any situation in which you have low calcium will induce relaxation of the receptor and unlimited PTH release. And of course, in hypopara, this mechanism does not work. We have again the inverse relationship between calcium levels, free calcium, and PTH. The lower the calcium, the higher the PTH, the higher the calcium, the lower the PTH. When we consider chronic, meaning lifelong hypopara, the current literature says that surgical determined situation or iatrogenic causes are majority, but on the long run they will start decreasing in prevalence because the autoimmune, non-surgical, genetic, idiopathic causes do increase. But currently we have 75%, 25%. When we think about non-surgical, we have to bear in mind either genetic agenesia, because parathyroids, superior and inferior, are from the third and the fourth brachial arch, and this is also valid for thymus. So this is why agenesia can be either isolated or coupled, as in the George, with thymus agenesia. Then we will have the alteration of receptor of PSA, TSH, or we have antibodies which will alter the normal function of parathyroid. When we think about functional, meaning self-limited, it can be seen after surgery, not thyroidectomies, nor secondary hyperpara, but actually in primary hyperpara. It can be temporary, it can last maximum out of 4 to 6 weeks. There are some situations in which they block the PTH function, like doxorubicin, ethanol, magnesium deficiency, aluminum, or cimetidine. And neonatal, normal newborns coming from mothers with hypercalcemia due to primary hyperpara, when they reach out from the internal maternal system to outside, the mechanism in any situation when the maternal hypercalcemia is higher than 20 milligram in deciliter, how does it work? So we have one adenoma, or in the neonatal hypercalcemia, we have maternal hypercalcemia. So hypercalcemia will induce the inhibition of normal parathyroid tissue. And when this is, the hypercalcemia does acute disappearly, either by parathyroid adenoma excision or delivery, we will have the remnant structures which are suppressed because of the long-standing previous hypercalcemia, and they need time in order to start function up to 100%. So we will have a self-limited period of hypocalcemia. We have also the entity called pseudo-hypopara, meaning it seems to be a hypoparathyroidism, but actually the PTH mechanism is intact, but still we have hypocalcemia. It's actually a PTH receptor insufficiency. So it's the lack of target organ response capacity to PTH. From the clinical point of view, we have the same hypocalcemia with all the signs and symptoms induced by hypocalcemia and by hyperphosphatemia, but we don't have low levels of PTH. We will have high PTH levels, but we will have the absence PTH receptor at the kidney and bone level because we have a PTH receptor deficiency. When, despite which situation we have no PTH, we won't have activation of bone turnover, so we will have a decreased calcium release from the bone. We won't have activity at the level of kidney, so we won't have calcium reabsorption and phosphate secretion. So we will have, won't have phosphaturia and calcium reabsorption. We won't have activation of 1,25 hydroxy vitamin D because of lack of PTH. effect on 1-alpha hydroxylase, so we will have a decrease of calcium and phosphate absorption at the level of intestines. So when we conclude, we will have low calcium due to decreased bone release, kidney reabsorption, and intestinal absorption. We will have high levels of phosphate because we will have a decrease of phosphaturia, because as we discussed before, the phosphaturic effect of PTH is higher than the intake from the bone and intestine points. Clinical picture will be acute direct effects of severe hypocalcemia, which are mainly neuromuscular signs and symptoms, and chronic, which is because of long-standing non-severe hypocalcemia, cardiac effects, ophthalmic effects, dermatologic effects, dental effects, and cerebral effects. When we think about neuromuscular excitability, we do have to bear in mind that it's not only always or not only about calcium. Whenever the ratio is high, we will have increased neuromuscular excitability, meaning low calcium, low magnesium, or alkalosis will increase the ratio. High kalium, high phosphate, and alkalosis will increase the ratio, meaning hypocalcemia, hypomagnesemia, hyperkalemia, or hyperphosphatemia or alkalosis will all increase the neuromuscular excitability, and the clinical picture, the acute clinical picture, is the same. So whenever we have signs and symptoms of hypocalcemia, we have to differentiate it from the signs and symptoms of hypomagnesemia, alkalosis, hyperkalemia, or hyperphosphatemia. Latent signs, meaning chronic effects of hypocalcemia. Latent signs can be an indirect sign of showing low levels of calcium are seen if levels of calcium are below 8.5 till 7.5. It's the hyperexcitability, neuromuscular hyperexcitability, Quoshwek, Trousseau, provoke hyperpnea, or Weiss-Luz sign. Quoshwek, you do make a pressure either here on the facial nerve or here, and you will have a Quoshwek 2 phenomenon, contraction of the entire facial muscle, or periorbital will contract. So these are the points in which you have to make a short high frequency low pressure impulse. Trousseau, 3 minutes of compression that will induce ischemia if this induce abduction and of the end of the finger and contraction of the fist. It's high relevant for latent hypocalcemia. Trousseau signs, so he was Quoshwek 1 here, Quoshwek 2 here. Trousseau is the zygomatic arcade, and this is the sign yet you get, and also latent hypocalcemia. Chronic signs of hypocalcemia, we have to think about cardiac effects. So it's a long QT, meaning delayed depolarization, that will alter the coupling of excitation and contraction. So it can favor long-standing and refractory congestive heart failure. Ophthalmic effects is subcapsular cataract, which is typical signs and symptoms of cataract, meaning seeing blurred and with reduced visual acuity. Dermatologic effects, flaky, brittle nails, dry skin. Dental effects, dental aplasia, hypoplasia if hypoparoid seen in children. Emaneltrophic problems, the same, brown striation, brittle teeth, typical for long-standing childhood untreated hypocalcemia. Cerebral effects, due to it can be seen only untreated long-standing disease from the childhood onwards. It can induce the calcification of basal nuclei with focal seizures or generalized seizures or intellectual deficiency. Clinical picture that we think about when we think about hypocalcemia is actually the acute clinical picture, describing situation in which calcium is below 7, and it actually tetany, which means tonic muscular contraction, even if the first signs are tingling paresthesias of the finger at the level of periorbicular muscle. So it starts with tingling, then goes, if the hypercalcemia continues, in adduction of the thumb, flexion of the metacarpial joints, extension of interval and flexion of the wrist, extension and abductions of the hip, flexion and extension of the toes. And it's important to know that these signs are actually, these contractions, you cannot move your hand, you cannot relieve the contraction, you cannot correct it, even if you apply external force. And if untreated, it goes to generalized painful involuntary contraction of laryngeal muscle, of pyloric and gastric muscle, dysarthria, anxiety, panic due to all these signs and symptoms, and it goes in direction stupor and death. Positive diagnostic is suggested by, let's say, clinical clues or etiopathogenetic context, but it's always a chemical one. So it's hypocalcemia. Attention, is hypocalciuria, because we remember that from the calciuria that we get to see, 40% is PTH related, but 60% is osmotic mechanism. And it is clear that in a system with hypocalcemia, we won't have active excretion of the calcium, and the system will be with hypocalciuria. And of course, not only total calcium, but also the ionized fraction of the calcium is low. By the opposite, we have low phosphaturia, because PTH is the most important active mechanism of phosphaturia and is impaired. And of course, due to the low excretion, we have high quantities of phosphate in the blood. And of course, PTH is really, really low, regardless if it's a functional or organic cause and regardless the organic situation. When we think about differential diagnostic, we have to make the diagnostic of all other situation of hypocalcemia and other situation of neuromuscular hyperexcitability. So when we consider hypocalcemia, so we have hypoparathyroidism, which is low calcium, low in urine, both in urine and in blood, hypophosphaturia and high phosphate. And we will have always low PTH and low 125 vitamin D due to lack of activation. In pseudo-hyperpara, the mechanism is the same, calcium phosphate, but we will have, due to PTH impairment at the level of receptors, high PTH levels. We will have normal or low 125 dehydroxy, depending on the degree of renal PTH receptor insensibility. Vitamin D deficiency means because of low 25, we will have low 125. We will have, here should be a high PTH, but we will have low calcium and in blood and normal phosphate, because PTH is normal at the level of kidney, PTA, but we have the impairment of absorption at the level of intestines. Type 1 rickets, meaning inability of the system to produce 125 hydroxy vitamin D, we will have the same thing, but we will have very high PTH. Because of the high PTH, we will have normal urinary phosphate and low phosphate. In type 2 rickets, because we will have an alteration of vitamin D receptors, even if we have normal 25 and normal production of the vitamin D, due to the lack of or the insensitivity on 125 vitamin D receptors, we will have very low calcium in the blood because of alteration of absorption. Differential diagnostic of hypocalcemia, so different forms of hypoparathyroidism, functional and etiologic, organic functional etiopathogenetic forms, resistance to PTH, which is pseudo hypoparathyroidism, 125 hydroxy failure, which can be in type 1 rickets, renal 1-alpha hydroxylase deficiency, or 125 resistance, in which it's the type 2 rickets, which we discussed already. Also acute complexation of calcium, acute hyperphosphatemia, acute pancreatitis, transfusion with citrate blood, excessive bone mineralization like in hungry bone syndrome, osteoblastic metastasis, or overtreatment with vitamin D. In all situations, we have an enhanced intake and movement of the calcium from the blood into the bone. It's a very avid for bone compartment. We have to bear in mind the ratio, so whenever we have hypophosphatemia or alkalosis or panic attack, we have the same neuromuscular increase excitability, and the same has to be valid for hyperkalemia and hyperphosphatemia. The treatment of acute forms of hypoparathyroidism, actually it's the acute treatment of hypocalcemia. It's an acute IV treatment, which at the first you give in the first 10 to 20 minutes 100 milligram of elemental calcium. Bear in mind that elemental calcium is the total calcium. It's not what is written in to the ampoule, but is the actual calcium content. If not enough, meaning there is not a resumption of the symptoms are still there, you can go on 100 milligram elemental calcium an hour, and always associate with magnesium, because magnesium depletion can induce functional hypoparathyroidism, and actually the symptoms do overlap, and in the acute situation you cannot make the active differential diagnostic between hypocalcemia and hypomagnesemia. Then, on the long term, we have to consider that any situation with low PTH will induce, even if we have normal quantities of 25 vitamin D at the level of kidney, regardless if it's from the screen or from the food, regardless if it's animal food or vegetal food. So regardless the entrance gate, we have the first hydroxylation in position 25 at the level of liver, and whenever we measure calcidiol, we have a clear image of all the intakes of the system. But regardless how good or bad is our 25 hydroxy or calcidiol reserve in the body, this calcidiol has to be activated in the final form calcitriol by the action of 1-alpha hydroxylase. And this 1-alpha hydroxylase, in order to have enough calcitriol, we have to have enough nephrons, the active vitamin, the active enzyme, and also active PTH. And whenever we have an impairment of PTH action, we'll have an impairment of calcitriol activation. So this is why on the chronic hypocalcemia treatment, besides huge quantities of calcium, and we need 1 to 3 grams of elemental calcium a day, and consider that we do not have in any tablets 100% elemental calcium, we also have to have vitamin D correction, but actually we have, because of decreased activation, always to use active calcidiol preparation or calcitriol preparation, and also to bear in mind long-standing magnesium correction deficiency. Elemental calcium is not 100% calcium, but it's part of the salts. So calcium carbonate has 40% elemental calcium, citrate 20%, lactate 13%, gluconate up to 10%, hydroxyapatite 35%. So when we have 1 gram of calcium in a tablet, actually we won't have 100 milligrams of elemental calcium, we'll have just part of it. Combined preparation goes up to 30%. So this is why in the previous slide I told you, again, 1 to 3 grams elemental calcium a day, and think about this because it's not 100%. Because we said that 75% of hypoparathyroidism are actually these, think about it as how we deal with it. So 1 to 4 days after surgery, we can develop hypocalcemia and signs and symptoms, which can be hypoparathyroidism, either transient or chronic, or hungry bone syndrome. Hungry bone syndrome is an avid bone for calcium and is usually in situation of uncorrected and untreated secondary hyperpara. Whenever we have alteration of the parathyroid, either functional or organic, we have always low PTH in the serum. But if we make the measurement 1 up to 4 days after treatment, we do not know if this is long-standing or functional. So we have to sustain the body with calcium and active vitamin D preparation, and on the long run consider down titration of the replacement therapy, meaning vitamin D, active and calcium. And if there is no relapse of hypocalcemic signs, we do conclude retrospectively that these symptoms were because of transient hyperpara. If there is a relapse of hypocalcemia, then which can occur, or if they occur more than 6 months after the surgery, we have to consider the chronic hyperpara. Personally, I do not make a titration. I just measure PTH here. I sustain the body with calcium and active vitamin D. I do the PTH reevaluation 1 month after the surgery. If it's normal, I down titrate. If it's low, I keep it, the system with calcium and vitamin D, and I remeasure it 6 months after in order to make the differential diagnostic and to not to put the patient through the really bad signs and symptoms of hypocalcemia. Down titration on the long run is because there are different sites of absorption of calcium and vitamin D along the intestinal tract. And on the long run, the need of calcium supplement and active vitamin D can be adjusted accordingly. But when we consider the treatment of hypopara patients with conventional treatment, meaning calcium load and active vitamin D, usually, even if they do not develop acute symptoms which appear below level calcium of 6.5 or below 6, the vast majority of them are a long run here at the lower normal range or a little bit lower than the lower normal range. So they won't reach usually more than 9.5 milligram a deciliter. And this low normal range of calcium will induce the chronic effects when we discussed about cardiac, dental, skin, ophthalmic, and cerebral side effects. And this is why in situation in which oral calcium salts and active vitamin D metabolites do not adequately control the calcemia, we have the second line treatment, which is not para, which is supplemental treatment with synthetic PTH on daily regimen. But because there were some 135 fragment of PTH black box warning that it can induce some treatments. So systemic exposure to teriparatide can induce osteosarcoma. Currently, there is a clear indication that we use not para, which is not 134 analogs, is 184 analogs, and this will increase in suboptimal treated patients the enhancement of general well-being. So never use 135, which 134, which is associated with the risk of osteosarcoma, always use replacement treatment of 184 PTH analogs, which is actually given in genetic diagnostic. Also, it can be delivered in chronic surgical hypopara if the control with calcium salts and active vitamin D will alter the quality of life and long standing. And standard of care is also magnesium supplementation, or attention to hypercalciuria under the treatment, and monitor kalemia under the treatment, not to overtreat the patient. So when we take the replacement treatment, it should be lifelong in genetic or surgical treatment. It should be on daily basis. It should be when we have uncontrolled parameters and alteration of quality of life, and is not for all the patients with chronic hyperpara, and is never used for functional hyperpara. Functional, it can be can go up to 6 months, calcium salts and active vitamin D, calcidiol or calcitriol. Definitive treatment if it's lifelong. This is conventional treatment, but take in mind that it is also 184 PTH synthetic preparation. We move forward to the next topic, bone turnover and osteoporosis. So it's important for me not to overlap hypoparathyroidism or hyperparathyroidism with osteoporosis. They are three complete different entities. When we think about osteoporosis, we do discuss about bone turnover, and we know that bone turnover means gap of the osteoclasts, activation of the osteoblasts who make a gap, bone resorption. They will release some chemical substances, followed by bone formation of osteoid by osteoblast, and then deposition of calcium phosphate salt in order to have a final healthy new bone. And usually these two mechanisms between osteoclast and osteoblast are coupled by different type of stimulus, and one of the major thing is the Rang ligand mechanism, in which the precursors of osteoclast, which can be activated, are activated by a Rang ligand. This is a chemical substance produced by osteoblast. Does fix themselves at the level of, here is a receptor, it's called Rang, and does activate the final osteoclast, meaning there is a perfect couple between bone resorption and bone formation. So this is how it has to be easily taken into consideration. But in osteoporosis, we will have an impairment of the mechanism of bone turnover, because we will have the activation, either the supraactivation of osteoclast or the down activation of osteoblast, meaning there won't be a perfect couple between bone loss and bone formation, with a netto minus that goes with time in increase. So bone turnover, usually 10% skeleton renewal per year in cortical bone, meaning every 10 years a new cortical skeleton, and it goes up to 25% renewal per year in spongious bone, meaning complete new spongious skeleton in 4 years. Yes, and it's again the same thing. Osteoclasts do repair the micro cracks and osteocyte apoptosis, the old bone, and osteoblast will do new osteocytes and new bone. And the gap is either this type of geode in trabecular bone or Haversian channels in cortical bone, and this is how it goes. The same discussion of chemical coupling of osteoblast and osteoclast activity. Yes. So again, osteoblast will release a rank ligand. Rank ligand is the final activator at the level of the rank, which is the receptor of active osteoclast. And osteoblast will produce osteoprotegerine, and osteoprotegerine is a competitor at the level of receptors of rank ligand. And usually the overactivation of osteoclast is somehow controlled or tapered by the osteoprotegerine release. When we think about bone mass evolution, which means not only growth but also density, accumulation of bone from the quality point of view, we'll have a period of growth in which formation is higher than resorption till we reach the peak bone mass. Then we have, let's say, the steady state. Then we have the normal evolution in which the resorption is more than formation. And typical bone loss period is the period of menopause in which the hypoestrogenemia will induce an overactivation of osteoclast. And around more years, 80 years of age and more, we'll have also alteration of formation. Peak bone mass, meaning the concomitant effect of genetic factors which are responsible for around 80% of our bone quality, hormonal factors, the quality of growth process and of puberty, mechanical factor, the degree of how active the system was during the childhood and adolescence period, nutritional factors, because of course low protein intake, diets, alteration of calcium and vitamin D will induce an alteration of bone quality. So the amount of bony tissue at the end of skeletal maturation is considered to be the peak bone mass, and this has to be considered the reference when we evaluate the phenomenon of bone loss or bone aging. So this is the peak bone mass that we, from the populational point of view, any of us will reach somewhere between age of 20 to 30. So this is the period in which we consider the reference from the populational point of view. Of course, while some of us will reach the upper normal range, some of us will reach the normal range, and then from this point we start losing. Till the menopause, the rhythm of loss is very, very slow. After the menopause, the rhythm can be different, either fast, very early menopause or normal menopause with fast losers and normal losers. Of course, the lower the peak bone mass in the peak bone mass period, the higher probability to reach the point of the diagnostic of osteoporosis. Because actually at the end, osteoporosis, as from the definition point of view, is a convention. When we look here, and if this value is the 0 point, everything what is below plus 1 upper, plus 1 minus 1 standard deviation, it has to be considered normal. Everything that is below minus 0.1 to minus 0.2.5 standard deviation to the reference value, which means reference normal mean bone density in the population between 20 to 30 years of age, this is osteopenia, and everything that is below minus 0.2 standard deviation to the reference is considered osteoporosis. And of course, the lower the peak bone mass, the higher the probability, and this is how it goes for male population, which accumulate more bone mass because of height, because of testosterone milieu, and because of the delayed puberty. It goes 1.5 years to the female population, and then the acute bone loss in menopause, which is because of the sex steroid drop in menopause. And here is just a very slow low slope, because we don't have an acute testosterone loss in the aging male. We have just a slow decrease, and which is not even universal present. And because of this bone loss, we have also not only a decrease in density, but also an alteration of the architecture. And at the end, everything will induce increased sensitivity to fractures. So osteoporosis means low density and alteration of the not only of the density and also of the mass and also of the architecture, which will increase the probability of fragility fractures. Fragility fractures means when you fall from the same level. So it's not a traumatic fracture that we are dealing with, is non-traumatic from the same level fall type of fracture due to, again, decreased bone mineralization density or alteration of bone microarchitecture. So osteoporotic intrabecular bone means higher spaces of osteoclast action sites with alteration of the density and of the architecture. From the cortical bone, meaning higher sites of osteoclast, meaning higher, bigger, more frequent, more big in size Haversian chellus. And in both situation we will have the higher susceptibility to fracture. Again, what means below 2.5 standard deviation according to the standard of the population, meaning mean bone mineral density in the same gender and race population, young adults between 20 to 30 years of age. Why? Because in this interval, for sure, each and every one of us will have reached his maximal individual point. And bone loss starts after menopause. It's after 50 years of age, and it goes, this is cortical bone will increase, especially in this category, and also here. A trabecular bone, because the turnover is higher in 2.5 times to the cortical bone, will be much more prone in the first years after menopause. But do understand that we do not have bone loss only after menopause. We have more enhanced bone loss even after the age of 64 to 65. So it's a matter of how much, the percentage of how much we lose, but actually it increases with age. So this period is much more prone to have bone loss, even if it's not the first 5 years after menopause. So this is the perfect coupling model in which what we lose, we get back. In postmenopausal osteoporosis, because we have an enhanced loss by osteoclast activation, we have some minus. And in uncoupling bone model, which is over age of 80, we have almost inability of the system to have osteoblast activity. And of course, because trabecular bone is the first to be altered, and it is, let's say, felt sooner. Vertebral fracture because of the trabecular bone loss appears sooner than cortical bone fractures, which is hip. It is delayed, but doesn't mean it's in a lower percentage. Actually, it's even in higher percentage. And what we have here, so low, how does it work? Low estrogens will enhance the quantity of rank ligand molecules. First, it will decrease the osteoprotegerine molecules produced by osteoclast. We will have an overactivation of the precursor of osteoclast in the mature osteoclast. So we'll have an overactivation of osteoclast due to lack of estrogen. So low estrogen will induce, because of low osteoprotegerine, overactivation of osteoclast, mature osteoclast, that will again overactivation to the lack of osteoprotegerine, and will induce an increased bone resorption because of overactivation of osteoclasts, and because of uncoupled to the osteoblast activity, we will have a minus. So this is osteoblast that comes, which are not 100% coupled, and we will have a netto minus, a netto bone loss. So meaning, because of the phenomenon, this is how an old woman bone looks like, and it's very clear that this one is much more prone to fracture after a fall than this one. So primary osteoporosis means the natural phenomenon that we did discuss previously, and is because of aging, and is either after menopause, lack of estrogen, overactivation of bone resorption. Trabecular bone is much more affected. Vertebral fractures goes up to 5 to 10 years after menopause, seen in females. Type 2 is the senile involution over years of 80, cortical bone alteration, alteration of bone formation, and is mandatory, not mandatory, characteristic actually, femoral neck fracture. Secondary osteoporosis is whenever we have the same mechanism which appear not due to the normal involution of the body, but because of corticotherapy or any situation of high glucocorticoids, high thyroid hormones, primary hyperpara, secondary hyperpara, hypogonadism besides the normal menopause. Hyperprolactinemia, any situation in which we have amenorrhea more than 6 months, growth hormone deficiency of diabetes mellitus, or any situation in which we have impairment of bone mineralization or of gastrointestinal calcium and vitamin D absorption, and also of protein absorption actually. Clinical point of view, vertebral fractures, chronic vertebral fractures which are not felt acutely by pain will induce decrease in height. Pain because of changes in the postural position, acute fracture, acute pain, and decreased rib sacral bone distance. Population and risk is logical to have the postmenopausal female population, so early menopause is one of the risks. Elderly over age of 80, both in males and females. Special category situation in which we have either early menopause or sarcopenia or any situation of secondary situations. From the not clinical point of view, the gold standard for diagnostic is the dual X-ray absorption metric called DEXA. T-score is called the standard for diagnostic, does permit the treatment efficiency monitoring, the monitoring of bone evolution in percentage of bone mineral density, and secondary osteoporosis, evaluating the Z-score, and some examples. So the WHO criteria are what we discussed, less up to 1 standard deviation to the reference population is normal, between -1 to -2.5 is osteopenia, below -2.5 with or without fragility fractures is osteoporosis. And also we can have the prognostic, the FRAX evaluation, and the treatment follow-up. So what means normal DEXA? So when we look here at the T-score, we have actually the same as here. So what is below -1 standard deviation to the mean, like here, so this is 0, -1 standard deviation to the mean is normal, regardless if we measure spine or hip. Where we perform measurements, always lumbar spine 1 to 4, because these are always present and are without any bone structures in front of it. And we also measure hip. This is suggestive for trabecular bone. This is suggestive for cortical bone. What means osteopenia? We look again to the T-score, -1 to -2.5 to the reference population values. So the device is on yellow. This is osteopenia. Again, -1 to -2.5 related to the mean of the standard population. Osteoporosis means below 2.5 standard deviation to the standard population, either at the lumbar level or the spine level. When we have here discordant values, we always take the worst from the two of them. So we always pick up the worst diagnostic for the two structures. Prevalence of osteopenia. Of course, it increases with age. The same is valid for osteoporosis. Bone turnover markers, it's just to know that there are some chemical substances which, if we measure, are highly suggestive for osteoclast activity. It's called resorption markers. There are some chemical substances, if we measure, they are highly suggestive for the phenomenon of bone formation, meaning osteoblast markers. They are not usually used for diagnostic, but for, let's say, research purposes. So bone turnover markers, again, some examples. These are enzymes from osteoclast, and these are collagen structures, and bone resorption are actually substances that are related and excreted from the bone. Other diagnostic evaluation, we can use spine X-ray in order to make the morphology of spine and to have a positive diagnostic of the fracture and of the degree of the fracture. And we can also have the evaluation of acute vertebral fractures by using MRI, and also peripheral tomography for as an alternative for the positive diagnostic. So this is an acute vertebral, a recent vertebral fracture. Here is what left from the vertebral body is a collapse more than 80%. And this is also an old. Here is the fracture, which is around 50%. Here is also with the edema, and the prolabation here is without edema, and this is why we can say this is an older fracture. Intervention is a targeted intervention, meaning we have to control bone turnover. So lifestyle changes, active screening, prophylactic treatment, active treatment monitoring, and patient compliance all will influence the targeted intervention. Again, what means risk? Who do we aim to target in our treatment? Clinical risk is the presence of fragility fracture previously. Densitometric risk is the value of T-score below 2.5. Anamnestic risk is the characteristics and the risk factors of each individual patient. When we look into the individual risks, it's a calculator which is valid for all the countries. This is the page for Romanian sites, and we have to take, or the computer, the risk computational is about age, gender, height, weight, and of course BMI, prevalent fracture, family, direct relative with hip fracture, active smoker, glucocorticoid use, or any other secondary osteoporotic cause, daily alcohol intake, and of course the bone mineral density at the level of hip, and we have values. And this is what we consider actually age. It's interesting, the Swiss system gives also what means secondary osteoporosis, type 1 diabetes, osteogenesis imperfecta, hypogonadism, premature ovarian failure, chronic malnutrition. What means 1 unit of alcohol? It's 8 to 10 grams an alcohol serving, so 3 units is more than 30 grams of pure alcohol on daily basis, and this is how does it look. What is important to treat? Because one pre-existing fragility fracture will increase the risk of future fracture by 86%. So when we have a risk, will double the vertebral risk, fracture which will increase by 5, the hip fracture, which will double the risk of death, because a year after the hip fracture, 80% of the patient will have the inability to be independent, 40% will have the inability to walk, 20% will be on daily bed care without impossibility to move, 20% will die. And globally, 8 out of 10 females with osteoporosis will remain untreated. Prophylactive intervention means calcium, vitamin D, prophylactic intervention to block the mechanism of bone activation of bone resorption by estrogen and estrogen modulator receptor medication. And medication means to influence the bone turnover, meaning anti-resorptive bisphosphonate, denosumab, calcitonin, or stimulating formation, strontium nalanate, which is not in, it was withdrawn from the market, but it was a very, very interesting molecule, or synthetic PTH-related protein. When we think about calcium, the daily calcium intake goes between 800 to 100 milligrams a day. Pregnancy, postmenopause, and adolescents will have higher needs. Still, calcium, as we see before, deficiency, so hypocalcemia, is actually consecutive to either vitamin D deficiency or PTH anomalies. So using calcium-only salts administration is really with no use. So we have to focus our attention on vitamin D deficiency. All values higher than 30 milligrams nanograms per deciliter are considered to be normal. Everything what is below 30 is insufficient. Everything is what is below 10 is severe insufficiency. Re-emphasizing that we have to measure 25-hydroxy vitamin D levels or calcidiol in order to know which or how is our level of intake regardless the gate of entrance. The prevalence of vitamin D deficiency is really, really high. This is valid for menopausal population because more than 80% of the postmenopausal population can be deficient. And this is for NANES 2010 in all age groups is really, really prevalent. So this is menopausal, postmenopausal population. This is the entire population. Treatment, emphasize on natural sources, always supplemental. Activating compounds only in situation in which have either liver activation alteration, renal activation alteration, or both. From the diet point of view, these are some examples. Which type of food, how many vitamin D do they contain? We have usually, in case of insufficiency, a load regimen which goes up to 2,000 units a day, 6 to 8 weeks, and then verify the level and maintenance between 600 to 1,000 units a day. Of adult population, there are some different types of loading regimen. Usually you load it with 600,000 units, and then once you reach the normal point, you maintain it with levels between 1,000 to 2,000 units a day. Special situation, malabsorption, chronic obese, anti-epileptic, long-standing medication, or after bariatric surgery, these special situations need maintenance dose is really, really high compared with what you usually do. Active medication, so we can deliver either estrogen replacement to ADMER treatment in order not to overactivate the osteoclast by increasing the osteoprotegerine quantities or decreasing the rank ligand production, or we can compete at the level of receptors with the denosumab, which will alter the link of rank ligand at the level of their receptors, or we can use bisphosphonates or calcitonin in order to block the activity at the level of bone of osteoclast, or we can use recombined PTH PTH in order to overactivate the osteoblasts. So we have anti-resorptive treatment, again, estrogens, receptor modulator selective estrogen molecules, bisphosphonates, calcitonin, and rank ligand antibodies, which is denosumab. Or we can have bone formation, and currently only 184 recombined PTH is present, and we can use all of them both in treatment and prevention of postmenopausal osteoporosis, glucocorticoid or induced osteoporosis, and also in male osteoporosis. But bear in mind that even if we have after treatment a reduction of fragility fractures of anti-resorptive treatments, this is not a 100%. The most performant is denosumab, both at the level of vertebral, non-vertebral, meaning wrist and hip, but also good values for alendronate, zoledronate, and risendronate. Bisphosphonates can be used up to 5 years of age. Denosumab goes up to 10 years of age. This is how bone density does increase with time compared with the other ones. Bisphosphonates, ibandronate, here is risendronate, zoledronate. And post-bisphosphonates, meaning what we can do after the 5 first years of treatment in which the bisphosphonates are active, we can move either to denosumab or to zoledronate, which even 5 years after bisphosphonates, which are the first generation of treatment, will maintain the efficiency. When we do talk about teriparatide, we have to bear in mind that between activation of bone formation and activation of bone resorption, there is a gap. It's called the anabolic window, and this can last up to 1.5 years. So first line is one of these, and whenever this is not enough, we can move to second line, which is denosumab, zoledronate, denosumab plus PTH or PTH, plus denosumab dependent on level. So first line we go this is second line, and this is how it is. Monitoring is always with DEXA, and we do not look on the T-score, we just look on the percentage of bone mineral density. So we make measurements either at the level of spine, and we will see an increase in bone mineral density, or at the level of hip, and this is how it works. Lack of answer means fragility fracture which appeared under treatment, or any situation in which from 1 year to other we have more than 5% bone loss at the level of lumbar spine or at the level of hip. So this was the lecture for today. I hope you had great Easter celebration with your beloved ones. And the next lecture that will be also available on line.